High tibial osteotomy. When is it a valid option? Basically, it is a joint preserving procedure that surgically realigns the lower extremity mechanical axis. It unloads the arthritic injured compartment. It preserves the native bone stock, buys time before eventual arthroplasty, and can correct the sagittal slope to protect ACL and PCL grafts. There are two types of high tibial osteotomy: medial opening wedge and lateral closing wedge. However, medial opening wedge is most commonly done. Ideal candidates are people who are younger than 55 years old, 55 years age, or say 60 years of age. HTO is good option for people who are doing ground level activities like squatting. In osteochondritis dissecans, osteonecrosis, cartilage and meniscal procedures, HTO will supplement with deloading the medial compartment. In ACL deficient knee, we decrease the tibial slope while doing HTO to reduce the anterior tibial translation and thus protecting a reconstructed ACL graft. In PCL deficient knee, we tend to decrease the tibial slope to resist the posterior tibial translation, hence to protect the PCL reconstruction graft. It can also be done in posterolateral instability, combined instability. Basically, H2O is an option for varus malalignment and medial compartment osteoarthritis. But what if there is valgus malalignment and lateral compartment osteoarthritis? In such cases, with valgus malalignment with lateral compartment isolated arthritis, if we do a varus HTO, we would create an oblique tibiofemoral joint line which will increase the shearing force across the joint. So, in such cases, a distal femoral osteotomy is an valid option. Contraindications of HTO, high tibial osteotomy. HTO is not done in elderly patients, patients with less than 70 degrees of knee range of motion, patients with patellofemoral joint, patients who has lateral compartment isolated arthritis, patients who have degenerative diseases of patellofemoral joint, and also the patients who have arthritis because of the inflammatory conditions like rheumatoid arthritis. We should always get an Rosenberg view in initial stages of medial compartment osteoarthritis because in initial stages, AP radiograph will only show subtle signs that most of the time are missed. Also, the bone scan in initial stages shows the increased uptake in medial tibial metaphysis. HTO is done in varus malalignment with medial compartment arthritis in physiologically active person with varus instability needing slope correction. It can also supplement the cartilage and meniscal procedures. While arthroplasty is more favored than HTO in patients who are more than 60 years of age, who have bicompartmental disease, who have lateral meniscal issues, who have range of motion less than 70 degree, and people who has inflammatory arthritis. So basically HTO is a good option for selective population. So first step to make an HTO successful is a careful patient selection.